Welcome to Derm Drop, your TLDR in dermatology. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community that are interesting and impactful. Episode 5 begins with subungual amelanotic melanoma. If you didn't already have enough to keep you up at night, go ahead and add this to your nail differentials. This sneaky Pete started out as a cracked nail in the March 5th, 2025 JAMA Dermatology Images in Dermatology. The patient was a woman in her 60s who experienced atraumatic onycholysis and splitting, which led to a painful ulcer at the root of the nail bed and eventually a light pink and porcelain white patch around the nail. This, of course, was treated with a topical antibiotic because what else? Meanwhile, an enlarging quote unquote string like mass developed beneath the ruptured nail. On subsequent examination, a light pink plaque was observed beneath the atrophied broken nail plate surrounded by depigmented skin. Biopsy findings were consistent with a melanotic melanoma and the patient underwent digital amputation. Turns out subungual melanoma accounts for 2% of all melanoma cases, and 25 to 33% of those are amelanotic. So if you see a non-pigmented erythematous nodule originating from the nail bed, especially on the great toe or thumb where they are most likely to occur, consider subungual amelanotic melanoma. In this case, the surrounding depigmented patch likely represented immune-mediated regression. Sure, it's nonspecific and could be onychomycosis or nail lichen planus, but remember to keep glomus tumors, squamous cell carcinomas, and especially melanotic melanomas on your radar, especially if it's solitary and not responding to treatment. Pull out your dermatoscope and look for irregular linear vessels, dotted vessels, and/or milky red globules. That last one has an almost 78% predictive value for melanoma. And if you're not sure, biopsy. Our next quick pick is about Biobetters and bioparallels, which have emerged recently in addition to biosimilars. So, what in the bioproliferation are those? Well, first, a quick history to date. Biosimilars were introduced in Europe in 2006. In 2009, the Biologics Price Competition and Innovation Act, or BPCIA, created an abbreviated biologics license application pathway in the US and defined biosimilars as biologic products that are highly similar to their reference or originator products in quality, safety, and efficacy. Per the BPCIA, biosimilarity must be demonstrated through analytical studies, animal studies, and immunogenicity, pharmacokinetic, and pharmacodynamic studies if necessary, but not clinical studies. Since biosimilars debuted in the US in 2015, the FDA has approved 61 biosimilars referencing 17 originators, of which 41 have launched so far. So, what are biobetters? Well, biobetters are second generation biologics designed from existing biologics with structural or functional alterations, such as increased selectivity or stability, or decreased toxicity or immunogenicity to achieve improved clinical outcomes. So, let's give an example here. As you know, infliximab or Remicade is an intravenous reference or originator biologic by Johnson & Johnson approved in August 1998. Inflectra is an intravenous biosimilar by Celltrion approved in April 2016. And Zimfentra is a subcutaneous biobetter by Celltrion approved in October 2023. Zimfentra's subcutaneous delivery method reduces administration burden on clinicians and patients while producing better clinical outcomes, giving it quote unquote biobetter status. Bioparallels, however, are not innovators in the follow on biologics market. They are latecomers designed to compete on price only. Although they function very similarly to their originator biologics, they are structurally different to avoid patent violations and requirements to demonstrate equivalence or interchangeability in efficacy and safety. They are faster and cheaper to develop, but as novel agents, do go through the same approval process and requirements as new biologics. So let's look at another example. Loqtorzi, or toripalimab, is a PDL1 and PDL2 inhibitor by Coherus Biosciences in collaboration with Shanghai Junshi Biosciences that was approved in October 2023 for metastatic or recurrent nasopharyngeal carcinoma as a lower cost alternative to the PD1 receptor blocker Keytruda or pembrolizumab, but at a 20% discount. So, Loqtorzi may be considered a bioparallel to Keytruda. Thanks to Ivo Abraham, PhD of Matrix 45 LLC, and the Department of Pharmacy Practice and Science and Center for Health Outcomes and Pharmacoeconomic Research in the R. Ken Coit College of Pharmacy at the University of Arizona, and Karen McDonald, PhD of Matrix 45 LLC, whose editorial published March 5th, 2025 in JAMA Dermatology introduced me to the concept of biobetters and bioparallels. Our next quick pick is about preventing relapse after Accutane. If you want to prevent relapse, focus on cumulative, not daily dose. The sweet spot is 120 to 220 milligrams per kilogram. Previous observational studies showed widely variable relapse and retrial rates after isotretinoin. So Jenny Lai, PhD, and John Barbieri, MD, MBA, with Harvard Medical School and the Department of Dermatology at Brigham and Women's Hospital published a cohort study in the April 2025 issue of JAMA Dermatology that used claims data of almost 20,000 patients to overcome the limitations of small sample sizes, unrepresentative populations, and incomplete follow-ups associated with clinical datasets. The authors found that after completing a course of isotretinoin, 22.5% of patients experienced acne relapse, requiring systemic treatment, and over 8% underwent a retrial of isotretinoin. But relapse and retrial rates decreased with higher cumulative doses, up to 220 milligrams per kilogram, and increased with lower cumulative doses below 120 milligrams per kilogram. Of course, higher daily doses increase adverse effects, so the authors note that lower daily doses may achieve similar rates of remission as long as a sufficient cumulative dosage is reached. So tailor your daily dosing to patient goals and preferences in balancing course duration and side effects. In terms of expectations, female patients were significantly more likely to experience recurrence requiring systemic treatment, which may suggest more persistent acne into adulthood compared to male patients. This may be due to pathophysiologic factors such as polycystic ovarian syndrome, and/or it may reflect increased rates of dermatology engagement and lower thresholds for treating recurrent acne. Despite higher rates of recurrence, females had lower rates of isotretinoin retrial. This is perhaps due to the increasing use of spironolactone and the logistical barriers of iPledge requirements. So the bottom line, slow and steady wins the race. Nobody wants to relapse and go back on isotretinoin, so Goldilocks dosing is key. That means low enough that your patients don't mind staying on it until they reach 120 to 220 milligrams per kilogram, and high enough that they don't mind staying on it until they reach 120 to 220 milligrams per kilogram. Our next quick pick is for those of you who are hesitant to prescribe a JAK inhibitor for your older patient with uncontrolled atopic dermatitis. If that's you, you don't have to be. In the March 25th, 2025 issue of the Journal of Clinical and Aesthetic Dermatology, Researchers published a multicenter retrospective review of real world outcomes in 38 atopic dermatitis patients aged 65 to 96 years old treated with JAK1 inhibitors. And what did they find? Almost 95% tolerated their JAK inhibitor well. Of the two that didn't, one switched JAKs due to mood lability, and the other paused during hospitalization for septic pneumonia. So, a switch and a pause. We're not talking heart attacks here, and there were no clinically meaningful lab abnormalities. The authors note that a 2022 study published in the Journal of Drugs and Dermatology found equal or higher incidence of malignancy, VTE, and MACE among patients prescribed prednisone, methotrexate, or cyclosporine. They also found higher incidence rates of malignancy, VTE, and MACE in untreated elderly AD patients in the Kaiser Health system compared to those treated with JAK inhibitors, suggesting that there just might be a protective effect going on here. But did their atopic dermatitis improve? Yes, it did. Almost 95% got clear or almost clear. And 100% reported at least a 4-point itch reduction on a 10-point peak pruritus scale, with over 93% getting down to 0 or 1. With treatment durations ranging from 4 to 28 months, longer term data would be nice, but these are definitely reassuring interim findings. So don't gatekeep. JAKs are not just for the young. Fight JAKphobia. Our next quick pick is what to do if your patient says their skin is burning and you don't see a rash. Well, you ask them if they're on semaglutide. Researchers reported a case of semaglutide-induced generalized burning sensation in the March 4th, 2025 issue of the Annals of Internal Medicine Clinical Cases. The case involved an 86-year-old patient who presented with full-body skin discomfort without visible skin changes or gastrointestinal side effects 1 week after switching from dulaglutide, marketed under the trade name Trulicity, to semaglutide, aka Ozempic, Rybelsus, and Wegovy, 2 milligrams weekly, following a plateau in his weight loss. In addition to moderate to severe burning, the patient reported sensitivity to light touch and pressure. Symptoms resolved while the patient was off the medication for a month before switching again to liraglutide, marketed as Victoza and Saxenda. And although he discontinued that due to diarrhea, the burning sensation did not recur until he was rechallenged with semaglutide. This time, the patient started at 0.25 milligrams per week and slowly titrated to 1 milligram, which he tolerated. But when he resumed the 2 milligram dose he was initially on, the burning sensation returned, though it was not as severe, and the patient discontinued after 5 months due to medication shortage. While the mechanism underlying the burning sensation is unknown, the authors postulate that the reaction may have been secondary to antibody development. Although this is the first published case, similar anecdotal reports were found on social media, and an FDA adverse event reporting system query produced 29 cases of burning sensation and 46 cases of paresthesia, though the authors did acknowledge the limitations of that database. With the explosive rise of semaglutide and other glucagon-like peptide 1 or GLP-1 receptor agonists such as tirzepatide, marketed as Mounjaro and Zepbound, and exenatide, marketed as Byetta and Bydureon for diabetes and obesity, dermatology providers need to be aware of their cutaneous adverse effects. So get ready for GLP scalded skin syndrome to walk in your clinic. And that's it for Derm Drop episode 5. Thanks for tuning in. Hit the thumbs up and share with your colleagues, and tune in next time. Thank you.